Welcome everyone to today's program. I'm Max Green with Becker's Healthcare. The program will begin with a presentation and we'll have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You'll receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to turn the floor over to Brian Warren from Select International to begin today's presentation.
Thank you, Max. This is Brian. I manage the Healthcare Solutions Group at Select International. This is actually going to be a panel discussion. I'm going to moderate and pose questions to the panel. Please feel free to submit questions throughout the presentation through the box that's available to you, and I'll incorporate them as they make sense. And of course, Select International is thrilled to be sponsoring this. Each of the panelists is going to make a few opening comments, but then we'll have a discussion. And it's been our experience that this interactive format is always well received, and I'm sure that will be the case today because of the panel we've put together. Next slide, please. Dr. Alan Rosenstein is a practicing internist in San Francisco, an educator and consultant in healthcare management. He has extensive national and international lecture and consultation experience, including in the areas of nurse-physician relationships, disruptive behaviors, communication, physician stress and burnout, and cultural and behavioral factors affecting patient, staff satisfaction, and clinical performance. His research on disruptive behaviors has been cited in over 200 medical journals, so we're thrilled to have him here. He's also held numerous leadership positions, including as the Director of Professional Services at the Walter Reed Medical Clinic, Vice President and Medical Director for a number of organizations. So as you can imagine, he brings a wealth of experience and varied perspectives to this discussion. I'd also refer you to his recent article in the Journal of Psychology and Clinical Psychiatry entitled Emotional Intelligence, a Critical Tool to Understand and Improve Behaviors that Impact Patient Care. We at Select International have the pleasure of collaborating with Dr. Michael Guerin in our work with the University of Wisconsin Health System, where he serves as clinical professor of surgery at the School of Medicine and Public Health. He's also the president of the Wisconsin Surgical Society and medical director of the UW Health Medical and Surgical Weight Management Program. He holds several leadership positions and has an interest in new and innovative physician leadership approaches, and most recently he's been very active in forming the physician leadership team for UW Health's new hospital campus, UW Health at the American Center. And finally, Dr. Ted Kinney is the Director of Research and Development here at Select International. As an industrial organizational psychologist, Ted's extensive work with healthcare organizations allows him to serve as a trusted advisor to senior leaders and to navigate the often complicated culture of hospitals and health systems. He's really been at the forefront of the development of Select International's healthcare-specific selection and development tools, including those for physicians and executives, and he's going to bring to this discussion practical expertise in how to measure emotional intelligence and what to do with the results in a healthcare context. So we're thrilled to have this panel together. And as I mentioned, we'll go through some brief content. I'll pose some questions to the panel, but feel free to submit questions throughout, and I will incorporate them. Next slide, please. So our agenda today is a little bit loose, but we want to cover a few very specific topics. One, what changes are prompting a new interest in concepts like emotional intelligence, a concept that we've been utilizing for decades in other industries in healthcare. Obviously, what is emotional intelligence? I think we need to define it in a very practical way. How does it impact physician performance and career satisfaction and subsequently organizational performance? And then how can we use the concept of emotional intelligence in a very practical and effective manner? So we'll cover those topics. Next slide. One of the reasons that we started this topic or this discussion internally here at Select is that Ted and I were actually meeting with physicians several years ago who are on the board of directors of a health system that we work with, and we were talking about how to do a better job identifying and developing physician leaders. And several of the physicians commented on the fact that they had all taken tests on emotional intelligence. And while they found the information interesting, they really didn't know what to do with those results. So the results weren't in a healthcare context. There wasn't any insight into how to improve performance. So it was clear there was a gap, and one of the things we've been trying to do is fill that gap. And I think everyone appreciates the pace of change we're facing as an industry, but I don't believe that we've thought through necessarily what these changes mean for physicians individually and as a profession, and how that's going to impact organizational success. Because in reality, we're asking more of physicians than ever. We're expecting more of them, including expectations that go far beyond being effective clinicians, yet we aren't necessarily giving them the tools to succeed. So we're expecting them beyond clinical excellence to be adaptable and have a level of business acumen and be collaborative and innovative and be leaders in the way that we need them to lead now. But they don't necessarily come to us prepared to fill those roles, and we're not necessarily doing what we need to prepare them. So I challenge you today to think about those concepts in the context of the discussion that we're going to have. Next slide. So with that in mind, I'm going to hand things over to Dr. Rosenstein and let him take a few minutes to give us an overview of what emotional intelligence is and why it's important and some of his experiences. Dr. Rosenstein?
Thanks, Brian. That was very well said. Welcome, everybody. You know, before I begin, as you've heard from my bio, I've had years and years of experience of being a medical director, a vice president of integrated healthcare networks, PPOs, HMOs, IPAs, all the acronyms, as well as I continue to practice clinical medicine and internal medicine in San Francisco. But most of my career has been trying to work with physicians to try to get them to understand the world of change and how it impacts them and how to motivate them to do what they really want to do, which is to practice best medical care. It's just that everything seems to be getting in the way. So I look at emotional intelligence as a way to get physicians to better understand what their concerns and priorities are, what their attitudes are, and how they can better adjust to the pressures around the environment so they can have a successful outcome. And the successful outcome is providing best practice care and being proud of providing that type of service. So when we look at emotional intelligence, there's different names for emotional intelligence. Some people call it social intelligence, mindfulness, and empathy. But really it's the ability to understand, perceive, evaluate, and respond to your emotions and other emotions in an effort to get to achieve your objectives. So there's 4 components that I put here in emotional intelligence. The first is self-awareness. What that is to get a better understanding of yourself, what your trigger points are, what your biases are. The problem here is a lot of these tendencies tend to be very subconscious. But the more you can understand yourself, the better you can reflect on what you really need to do to adjust to the person you're intervening with. So the second part of self-awareness is self-management. If you understand what your trigger points are and what your particular biases are, then maybe you can better manage your attitudes and behavior to get the result that you want. The third part of that of emotional intelligence is social awareness. It's really being aware of who you're coming into contact with, what their values are, what their perceptions are, what their needs are, and try to manage the discussion or the relationship to achieve what you want to do in accordance with what they need to do. And the fourth part of it is just rolling it all into what we call relationship management. Next slide. So this is particularly important given the dynamics of what's happening with healthcare reform and value-based purchasing and accountability for performance that goes through certain metrics that measure outcomes as well as satisfaction. So because the market is so complex, there's many different components of the healthcare team, and they really need to understand how important it is to work together to achieve optimal results. So to get a better understanding of what the objectives are, what expectations are, what individual roles and responsibilities are, then we can promote team collaboration by emphasizing the importance of communication and care coordination. And in order to have effective communication and collaboration, we really need to get a better understanding of attitudes and behaviors that set the way people deal with particular circumstances. So in order to improve emotional intelligence, there's certain requirements. The first thing is that the individual needs to be receptive. And one of the issues with physicians, they're so preoccupied and so worried about capacity and time that they really just want to deliver patient care and they don't understand why they really need to change. So we need to make them more receptive, to motivate them and show them the value of improving emotional intelligence and improving patient outcomes. The first way to do that is what we call self-inquiry or appreciative inquiry. It's giving them an opportunity to better understand themselves. Again, it's self-appreciation. The second part is knowing others, being sensitive to what the values of the others are and trying to meet their needs as well as meeting your own individual needs. They need to be taught how to read the signs, to adjust their behaviors, and be willing to accept feedback to help modify the way they're providing care. Next slide.
We may have lost Dr. Rosenstein. Are you there, Dr. Rosenstein?
No, I'm here, but I don't have the next slide available.
Yeah,
there we go. Thank you.
It moved ahead. Yeah, go ahead. It must have been a slight delay there.
Okay, I'm sorry. So the first thing in trying to improve behavior is to really understand what the barriers are. Why do people behave the way they do? We really need to consider generational differences. You know, the 30-year-old is going to react differently than the baby boomer or the veteran. And it's not that their value systems are right or wrong. We need to understand what their value systems are so we can work together and compromise and be flexible in getting to achieve the task at hand. There are certain gender differences. You know, men, when they're under stress, they tend to work autonomously. They want to get driven to achieve the task. Whereas women typically are very gregarious. They look for other people to try and support their individual point of view. Culture is a big factor that affects people's attitudes and behaviors. Different cultures have different ways of addressing power gradients, the way they communicate, the way they look at gender differences, and we really need to take that into consideration when we're dealing with other individuals. And then life experiences themselves, that will shape the person's attitude and behaviors, and eventually it all leads into personality. So understanding what individual personality traits are is a better way to try to improve communication and collaboration. Those are the internal factors. The external factors are three here. The first one is training, and this is particularly true for physicians. Many people equate the medical training process as compared to a hazing process of a fraternity or a sorority. You start out with very low self-esteem. You quickly learn that you don't know anything. In order to know something, you study independently. You get technically competent. You get knowledge competent, but you do it by yourself, and it's the antithesis of good people skills and communication and collaboration. And luckily now the medical schools are beginning to recognize this and are beginning to change their core curriculum to introduce personal skill trainings in their students throughout their residency program. The environment, healthcare reform, and other types of initiatives, they're really stressing the physicians to the point of becoming more accountable for their performance. They're being told what they can and cannot do. They sense that they're losing control. They sense that they're overworked and nobody cares. And this is producing a significant amount of stress and burnout in the physician population, where many physicians are either leaving the practice of medicine prematurely or looking for different types of model of care so they can be more satisfied. So we have to take that into consideration when we're talking about improving behaviors and through emotional intelligence. The next is the need to change. Why do I need to change? So we really make the business case of you recognize that where it used to be silo, hierarchical type of care, we all need to communicate better and collaborate better. Of course, we need to provide effective care across the full spectrum of care. The motivation for change is that you feel happier with what you're doing, your customers feel happy, patients and the staff, you get better outcomes, you're more satisfied, you're more engaged, you re-energize the passion for providing best practice care. Next slide. So what are the solutions? One of the solutions is just simple education. It's keeping physicians aware of what's happening in the business world around them, how it impacts their practice. The frustration is, why are people doing all this stuff? Why aren't they looking at other metrics and other barometers of best patient care? But until we're able to change those metrics, they're still being held accountable, but we're here to help you. So educating them as to what the metrics are and what people are looking at and why it's changing is also gives them the opportunity to better understand why they need to change. Certainly putting physicians through emotional intelligence training. And as I mentioned with the medical schools, now a lot of the medical schools are beginning to introduce during freshman year both team collaboration dynamics as well as training individuals, and this is physicians, nurses, pharmacists, through emotional intelligence and team training. Diversity training would be advantageous. Providing training in customer service is particularly important given the Medicare pay for performance based on customer satisfaction. Certainly stress and conflict management. As I said, the stress and burnout in physicians is affecting more than 50% of the population. Teaching them ways to deal with the stress and managing conflict in the effort to improve their well-being, their ability to adjust with the environment is key to getting them to continue to practice. Communication skills training, team collaboration training are all crucial. And then staff support. The organizations that physicians work with, they really need to understand what the physician world is like. They need to be empathetic and at the same time give them an opportunity to express their concerns rather than just telling them what to do. This is all the principles of good, successful physician engagement. Let them express their concerns, give them input into care redesign, and then provide support. You could provide administrative or logistical support. Some of this may have to do with scheduling, with commitments, with on-call. You can provide clinical support, supporting some of their needs through the use of scribes, through the use of physician assistants or nurse practitioners, and then certainly behavioral support, giving them an opportunity to talk about what's going on in their world, what's bothering them, and you can do that through either coaching or counseling or provide more behavioral services depending upon what type of problems they may have. And then lastly, and as I said, most importantly, is to engage the staff. And physicians really need to understand what they need to do, but at the same time, they really need to understand how they're participating as part of a team and depend upon the nurses, the case managers, the therapists, the pharmacists to work together to get best patient care.
Perfect. That's
okay,
a great overview.
I'm going to turn it back over to you, Brian. Thanks.
Yeah, thank you, Dr. Rosenstein. Perfect overview, and we'll get back to some of these concepts with some Q&A in a minute. I wanted to hand things over to Dr. Kinney for a minute because now that we've defined emotional intelligence, what we'd like to look at, among other things, is how do we measure it more specifically in a way that's meaningful to improving patient outcomes and physician and organizational success.
Thank you. I wanted to start by underscoring the definition that Dr. Rosenstein provided us at the beginning. He described emotional intelligence as understanding, perceiving, and evaluating yours and others' emotions. I may not have said exactly the same way, but I think that's what Dr. Rosenstein in my note. So if you think about that definition, the concept there is about how we relate to others. So that's at the core of emotional intelligence. It has to do with how we understand how we're being perceived and how others are perceiving us in social interactions. So I wanted to talk a little bit about how we go about measuring that and to bring to the table a bit of background from some of the psychological research on the concept. And to be sure, there certainly is some disagreement in the research literature about what emotional intelligence is. Some people call it, an ability. Others do not. But to me, in the midst of all of this discussion and debate, I'm of the perspective that it doesn't really matter that much from a practical perspective. We're able to understand the concept of emotional intelligence by considering behaviors. And if we measure behavioral patterns across time, setting, and situation, we're able to get a pretty good understanding of the concept of emotional intelligence. So by measuring how people behave across time, setting, and situation, we're able to get a good practical understanding of how we understand and relate to others and how we understand our own emotions. So we're able to get an understanding of that definition that Dr. Rosenstein provided us by looking at these behavioral patterns. And when you do this, you find that you're able to measure some behavioral patterns that fall into some pretty clear categories. And these categories are very similar to what Dr. Rosenstein provided on his slide. And in this case, we tend to consider these categories as traits. And we then treat emotional intelligence as a combination of a collection of traits. So the particular traits do tend to vary depending on the researcher, but there are some very common themes throughout those traits. Emotional intelligence operationalizations tend to include traits such as self-awareness, social sensitivity, empathy, and self-esteem. These are pretty common. So in other words, then, we're able to think of and measure emotional intelligence as this meta-construct. So in other words, emotional intelligence is made up of a collection of a few different traits, of several different traits. And so to this point, most researchers do treat emotional intelligence measures as a meta-construct, but that's about where the state of the research has sort of stopped at this point. Most of the research at this point is really looking at, how to measure those traits or which traits to include, but then typically all of those traits are aggregated using a unit weighting approach where each of those traits within the meta-construct contribute the same amount of contribution to the overall emotional intelligence score. Now that's okay, but I think I think that we can and we probably should do better than that. For example, I believe that some aspects of the construct of emotional intelligence are more important in some situations than in others. This is why in some of the research that we're doing at Select International, we've moved into the direction of creating healthcare and physician-specific measures of emotional intelligence. So I'll talk about it using this example. We can think about physicians that we've met or encountered in our careers or even in personal interactions who are very high in self-awareness, very high in social sensitivity, even very high in self-esteem, but perhaps they're not particularly high in empathy. So these are the physicians that we may encounter who are aware of how they're being perceived. They just don't really care that much. So in a traditional measure of emotional intelligence, this person might score pretty high in emotional intelligence because they are self-aware. They do understand how they're being perceived, and they feel pretty good about themselves. But the one aspect where they're low might, in fact, be the most important aspect of the meta-construct in the physician's world. So we've done some research looking at the aspects of the meta-construct of emotional intelligence that are most important in healthcare and for physicians, and we've started to weight those more based on how they impact outcomes in a physician's situation. So this sort of situational interplay really helps us then understand what we can do with emotional intelligence. And I think that Dr. Rosenstein pointed out something very early in his presentation when he was talking about the goal of physicians. Dr. Rosenstein said that the goal is to practice the best medical care, but everything gets in the way. And that really is at the heart of the matter. Physicians want to drive outcomes. And I think that when we think about emotional intelligence, our message here is not that we're going to change somebody's level of emotional intelligence, but rather we're going to talk to physicians and say, okay, in that interaction, in that situation, you didn't get the outcomes that you wanted out of a social interaction. You didn't relate to the person the way that you wanted. So what about that situation caused that interaction to not go as well? So the idea is that by understanding where you score on these different traits in the meta-construct, by understanding how you tend to behave across these traits, across situations, across time, setting, and situations, you start to understand why outcomes, you might not get the outcomes in these interactions that you would like. And so then our goal in development isn't about changing somebody's level of emotional intelligence, but rather it's about understanding how to adjust your typical behavior pattern given the demands of the situation. And we're able to see that when, typically these highly intelligent physicians start to understand their current levels and understand how they can moderate their behavior in a situation to get the type of outcome that they'd like to see, they are able to make that adjustment. And over time, then, we see that level of emotional intelligence or the outcomes of these behaviors start to shift.
Thanks, Ted. And we're getting a number of questions about the best ways to measure EQ and the relationship between EQ and IQ, and we'll get to those. And I just wanted to give you another example we'll use frequently in our discussions is thinking of a nurse or a physician who might actually be high in empathy and really care about the patient, but might actually be low in social awareness and not able to pick up on a patient's needs. So in that case, measuring empathy isn't sufficient, and that's one of the things that's been driving some of our discussions. So let's move forward then and change the slide if you could, and let's talk about some practical implications, because Dr. Guerin, I know you're right in the middle of all of this. You're working with an organization that's constantly thriving towards improving physician leadership skills so that we can get patient outcomes and the changing nature of the organization. What are your experiences with the concept of emotional intelligence and some of these practical implications?
Well, thank you, Brian. Thanks for the invitation to participate. I can guarantee you that a significant portion of the crowd today, upon finding that I am a surgeon, are number one shocked to hear that a surgeon is interested in and much less espousing to demonstrate a level of emotional intelligence. I'm a mid-career surgeon, and those of my colleagues that are also in the middle of their career realize that when I was in training, I can guarantee you in the many years of my surgical training, I never heard the term emotional intelligence. As I've gone on, as Brian mentioned, at the University of Wisconsin, like many organizations, we have developed a robust physician leadership development program, of which I'm a graduate. A major portion of that training is this concept of emotional intelligence as it pertains to leadership. And I think the other thing that's going on in my career, in addition to a busy clinical career, is that I have become the chief medical officer of a surgical specialty hospital in the University of Wisconsin system. And this hospital is approximately 80% orthopedics. I'm a general and bariatric surgeon, so right then and there you can see some traditional challenges that we may have as in terms of leadership of such a facility. And this facility that we've opened, we've built very much on lean technology with the patient family at the center of every process that we've developed. And I think as physicians, we never really used to equate our patient outcomes with the concept of emotional intelligence. I think we feel that if we provide expert care, then we are providing the best possible patient care. And clearly that's not always the case. We're learning that patient perception is key, and our ability to relate to our patients with a degree of empathy and emotional intelligence is absolutely critical. And from a very practical standpoint, as a surgeon, I can tell you we can have the most complex patient that develops complications after surgery, but if we are able to deal with those in an empathetic, understanding way, then we're bound to have better outcomes. In terms of my organization, as I mentioned, we've built this new facility on the idea of lean and trying to get to this culture of continuous quality improvement. And there's one thing that's absolutely clear in that type of setting, that the role of the team is incredibly important. And traditional models of top-heavy teams dictating what goes on at every level of the institution just doesn't work anymore. And our our goal has been from the very beginning to develop a just culture in terms of our associates. And the lean principle is that anybody at any time can stop the line. And if the quote-unquote leadership, that being the physicians and administrators, are not able to demonstrate a level of emotional intelligence in dealing with every member of the team, then that just culture, I think, really can't develop. I like to draw from a book I recently read by General Stanley McChrystal called Team of Teams, and this idea of empowering people at every level of the institution to make decisions and move forward with our overall initiative. And then finally, the practical concept of physician leadership and the role that emotional intelligence plays in it. Again, anybody that's had any involvement in the healthcare system realizes that the way that we traditionally hire physician colleagues is really a bit outdated. We get a CV, we look at their academic record, we perhaps call for references, but do we really know how that individual will function as part of the team or as part of future leadership in our organization? At the University of Wisconsin here, pairing with Brian and Select International, particularly in this new institution, we have started to develop a new philosophy of how we hire fellow physicians. And that includes measuring emotional intelligence, doing much more of an executive assessment. In fact, the entire leadership team of this institution, even though we weren't new hires, agreed that we should all undergo this type of evaluation ourselves. Number one, to get some more self-insight, but also two, to demonstrate to our greater organization the value in measuring things before we hire our colleagues. I think we've all had experiences where there's been a regretful hire, and obviously in the physician world, that can be a very difficult thing to deal with. So again, in summary, at the University of Wisconsin and me personally, I think we're really trying to put more emphasis on this concept of emotional intelligence as we try to move our organization forward. Thank you.
Great, thank you, Dr. Guerin. That was a great insight as well. And I've got a whole host of questions here that are coming in, so I'm just gonna jump into these in no particular order. Dr. Rosenstein, I'm going to pose two questions to you, and then the others can chime in. What has been physicians' response to training in these concepts in your experience? So if you go into an organization and you want to talk about emotional intelligence, and you want to talk about its impact, how have physicians responded to this? Either physicians who are early in their career or physicians like yourself who are more established?
Well, there's no across-the-board answer to that, and certainly values and attitudes are more ingrained the older the physician gets and the longer they've been in practice. So the simplest answer is the older, and some may have a little more difficulty in adjusting. Why do I need to change? But the basic issue is the first thing is resistance. The thing is, I'm great at what I do. You don't understand my world. I'm so busy and so overworked that I don't have time to listen to any of this nonsense. That's the basic response. So what you really need to do is to get through all that, and you need to really pitch emotional intelligence as you are a precious resource. We know how hard you are working. We know you're overexpanded and overextended. What we're trying to do is we're trying to help you. So the first thing is to let them appreciate that, one, you understand their world, and two is that the design of this program is to help them. How do we help them? What's your main goal? My main goal is, as we talked about before, we want to provide best patient care. Well, part of what we can try to do is to give you some tools to make that really happen. So part of the tools is understanding what's going on in your world, understanding what's going on in the people you're interacting with, and how do you come to a happy medium where it's more efficient, the flow is better, there's no waste, no duplication, everybody's happy, relationships are good, and you get a better patient outcome. That's what it's all about. So when you finally open it up to the point of what's in it for me, and they can see the value of it, then they become more receptive. And then part part of emotional intelligence is to really get them to say, is this the person that I really want to be? So the idea is to present a construct that they can actually assess a situation, how they would handle it, and then ask them, do they think that that's the best way, and what else could they have done? So they begin to do a little bit of a reflection and introspection, understand, yeah, I could have done this a little bit better, then you've opened up the door and they're more receptive.
And I think to Ted's point earlier, you're not changing their level of actual emotional intelligence, because I think Ted will tell us that that's going to remain fairly static, but what you're doing there is giving them some tools, creating awareness, and changing behaviors, right, Ted?
Yeah, and this is, I think, a thing that makes it a little tricky, is that the term intelligence is a value-laden word in and of itself. So, you know, physicians are often not receptive if you go into a conversation saying that they're low in some type of intelligence, you know. So that can be a challenge. And, you know, if you think about the nature of the construct itself, you're typically not giving this feedback to folks who are high in emotional intelligence. Consequently, that means you're trying to get people to understand who are not particularly self-aware. By the nature of the construct, you're trying to get people to be aware who are not particularly self-aware. So it is a challenge. It is a hard thing to do. And I think that Dr. Rosenstein's comments are very, very insightful because that's the only way that I've actually seen it be successful. Pitching it in terms of helping them achieve their outcomes. Pitching it to say, hey, you're not getting, behaviorally, objectively, you're not getting the outcomes that you wanted from certain interactions. What is it that you could adjust to make those interactions go better so that you can get those outcomes? So it's not about making an internal attribution about the person. It's not saying that they're low in intelligence. It's saying, hey, let us help you. There are consistent patterns leading to why some of these interactions are not going the way that you wanted them to.
One of the things that we've done, and we did this with Dr. Guerin and his group, was frequently refer to grounding the discussion in operations. So these are busy physicians who have a certain thought process in the way they address challenges and problems, and too much discussion about psychology and the behaviors behind it and what's going on subconsciously is not as well received as, what are the operational challenges you're dealing with? How did you deal with them? What was the outcome? We change the behavior. So that's been good. I'm going to pose this question to Drs. Garrett and Dr. Rosenstein. I've gotten several questions about the potential for this type of assessment when we're looking at selecting residents or using these sorts of tools as training with residents and medical students. What are your thoughts on that? I'll start with Dr. Guerin.
Yeah, that's a great question. And I think you know, number one, anytime you're dealing with an academic situation, you may call it a piece of the pie, but I think a relatively small piece of the pie. Now, that being said, during residency training and during medical school, but I think particularly residency training, where traditionally we've kind of developed our practice personalities, I think that would be a critical time to introduce the concept and actually train folks on that. You know, I think the old constructs of how we train residents clearly has changed with duty hour restrictions and so forth. And in and of itself, that portends a little bit different attitude towards the trainees that we're putting out. So I think it's absolutely critical that we seize upon that opportunity and across all specialties to make this a really important part of their training.
Dr. Rosenstein, what's been your experience? I know we've had a few inquiries recently. We've been doing enough of this work that it's getting attention, that a few health system residency programs have contacted us, but we've not actually implemented anything yet. What's been your experience?
Yeah, and I'll just follow up with what I said. One of the things that medical schools are doing right now is they're actually trying to change the type of person that gets to medical school. The new MCATs now have a series of questions on humanities, and then for applications, they're looking more for people who didn't major in math and science. Maybe they majored in sociology. Maybe they majored in performing arts. What they're looking for is for individuals who are more well-rounded and have some grounded personal skills, because they recognize how important this is. So one thing is who's getting into medical school. The second thing is there's a growing amount of evidence of stress, burnout, depression, and even suicidal ideation in people going through medical training. And of course, the AMA, the Robert Wood Johnson Foundation, they have all these grants now trying to work with different medical schools to put in their curriculum personal skills training. Emotional intelligence would be one of those tools, as well as getting people more involved early on in the team collaboration process. So I think it's over would be an example where a medical student is paired with a nursing student, paired with a pharmacist, paired with a physical therapist, a respiratory therapist from day one, and they continue these daily rounds throughout their four years of training just to expose them to team dynamics and also to better experience what roles and responsibilities they have and what roles and responsibilities the others have, how to better interact, and that's basically promoting emotional intelligence. So I really think it's crucial, and I'm very happy to see that medical schools are beginning to change.
We've had a couple questions on a very practical note, and Ted, I'll ask you this. What are some of the tools that are used or that we recommend using to measure? Because we've talked about a few things here, a lot about training, but in our world, for instance, we don't start that training until we've done some assessment to understand the level. So what tools are out there? What are your recommendations?
Yeah, there are a lot of emotional intelligence measures that are out there, and rather than go through a list, because I think just a quick Google search can turn up a lot of different emotional intelligence inventories, I guess I would probably answer that by asking, or talking about what I would want out of an emotional intelligence inventory. And what I don't like to see is emotional intelligence measures that lead to a single score. Something that's saying that your emotional intelligence is X, because that doesn't give you enough information about how that person tends to behave across situations. So I'd rather understand what those different sub-constructs within the meta-construct, I would want to know their scores, where they're high and low in that, so that I can think about how each of those things relate to that particular person's behavior, the particular outcomes that they're getting out of their social interactions. So, there are some. Select International has measures of emotional intelligence, of course. The EQI is one that I've seen that I think is pretty decent. There are a lot of them out there, but I guess I would say that as you search for emotional intelligence inventories, I would look for ones that provide scores across the different quote-unquote dimensions of emotional intelligence.
And one of the things we've tried to do, we've recently built a tool that's specifically designed for physicians, and it has emotional intelligence in there, and it's very much in the context of healthcare. So breaking down the sub-constructs, and it says, within emotional intelligence, you're actually a little low in social awareness. What does this mean when you engage with patients? What does this mean when you interact with colleagues? So I think that's the specificity that we would look for in a test that has some real meaning. And what about, we've had several questions about whether there's a correlation between emotional intelligence and straight IQ. And Dr. Rosenstein, you may have some thoughts on that. What's been your experience or research on the comparison between EQ and IQ?
As not being a specialist in this particular area, I think there may be some correlation, but I think the problems, one thing is how you actually measure IQ. Typically, the physicians are very intelligent. They're very driven, they're very competitive, and they're very smart. Unfortunately, that may be the antithesis of developing good communication skills, because you're very authoritative. You have this underlying superego, whether that's right or wrong. You think that you know best. And when people have that type of attitude, they're less sensitive to the people that they're coming in contact with. And certainly in medicine, where it's a hierarchical system with the physicians on the top of the chain for the most part, it doesn't breed sensitivity. So there may be a direct diametrically opposed high IQ score with a high EQ score. So I'm not sure there's a good synchrony between the two.
Yeah, I tend to agree, Dr. Rosenstein. I think that the two concepts are largely uncorrelated. I think that our experiences with physicians point this out, that, like Dr. Rosenstein said, most physicians would score pretty high on most measures of IQ, but we see a tremendous amount of variance in measures of EQ. Suggesting that there isn't a particularly strong correlation. So even at those high levels of intelligence, it doesn't really predict what the level of EQ would be. And I think that Dr. Rosenstein made another very good point there too, is that when you have somebody that's particularly high in intelligence, they've used that characteristic, they've used that attribute about themselves to be successful. They lean on it. It becomes a crutch, and they figure things out, and they understand their world based on an over-reliance of that particular ability. So sometimes it can be hard to get them to move on emotional intelligence or adjust their behavior because they've had so much success throughout life just banking on the fact that in most situations they're the smartest person in the room. So that can create a challenge, to Dr. Rosenstein's point.
And while our database with physician testing is nowhere near as large as the database we have for executives, leaders, and other roles, just because it's relatively new, we are seeing some trends and patterns, and that physicians, particularly physician leaders, tend to score lower in emotional intelligence compared to leaders in other industries, simply because, as Dr. Rosenstein said, it's not been a requirement for success. We test a lot of department chairs. It's truly academic. It's about research. It's about clinical skill. But now there's a new skill set required, and that's why we're looking at that. And one of the questions that came out, and it's interesting, this question comes up almost every time we talk about behavioral assessments, is that if you're screening candidates for EQ, how do you avoid potential staleness or lack of diversity? And I would say first, and I'll give it to you, Ted, is we're not necessarily talking about screening. For instance, Dr. Guerin's team, I can tell you, did this strictly as a developmental task. And as a group of physicians, I can tell you they all scored pretty darn high in emotional intelligence, but there's a lot of diversity in opinion and thought and approach within that group. I think, Dr. Guerin, you would attest to the fact that your physician leadership team there has a great deal of diversity, and that's not been a problem, right?
Absolutely. I think that's absolutely the case. And I would just quickly add that while you do not tout this as a screening tool, I foresee a time in the future, right now more than 50% of physicians in this country are employed physicians. And I think that the employers are going to get the idea that this is a really important trait to examine when hiring new physicians.
Yeah, I agree. Our experience so far has been that, one, we're not measuring just emotional intelligence when we're talking about physicians and physician leaders. That's a component of these assessments, and they're wonderful developmental tools, and lots of different profiles can be successful. But once you understand the baseline and those innate tendencies, that you can use that as a developmental tool. And I think Dr. Guerin's point about physicians moving to an employment position is an important one as well. But the other question that's come up a few times is, who's best suited to do this training? Who does this sort of training, and who's best suited for it? Is it another physician, for instance, Dr. Rosenstein? Is that what's best received?
Well, if there's a physician who's well-skilled in emotional intelligence virtues, I think that's fine. Most of the programs that I have seen have really been conducted by people who are more in the social network, MSWs, counselors, coaches that have taken either special credentials or special courses, and they're the ones who have dedicated their lives to this. So most of the expertise tends to fall out from the physician sector. But I think now there are more and more physicians who are getting more interested in this, and if they build up the skill set, it's great. One of the problems with physicians, or we're finally beginning to see some change, is if they don't hear something from another physician, they don't accept it. So sometimes just having the credential of being an MD will at least get the other physician to trust you and to listen to you because you can sympathize with their world. So most of the trainers are not physicians. There may be a little bit of skepticism. If more physicians move into it, then better for everybody.
And Dr. Rosenstein, what's been your experience with the role of emotional intelligence in physician disruptive behavior? Because I know you spend a lot of time on that topic.
We have another hour. Yeah.
I'll give you 5 minutes.
No, I won't take 5 minutes. Okay. Most physicians, when you deal with disruptive behavior, there's a whole range. A lot of physicians who exhibit disruptive behavior don't even know that they're doing it. And once you bring it to their attention, I noticed you're screaming at a nurse. Is something really going on? Said, well, I wasn't really screaming. Said, well, look at her face. Said, yeah, well, she didn't do this. And then you finally think, well, is there a better way you might have handled it? So the first step with a disruptive physician is doing emotional intelligence from a one-on-one interaction. They didn't really mean it. So a lot of them will self-correct. And in the mid-range is the people who need a little bit of help. They don't know how to, they're either angry, they're stressed, they're harassing, they're intimidating. You really need to provide training programs in either stress management, anger management, conflict management, diversity management, to try to get them to understand their ways. Now, really, emotional intelligence is the same thing. It's just a little bit broader. So some of them will require that type of individualized sessions or individual coaching to help them better adjust and to better handle the situation. And then there's a small group who just, no matter what you do, they don't care, and they're just going to continue, and they don't make any effort to change. And then the organization is stuck with the fact of what do we do with this physician, and then you get into credentialing and sanctions. What I try to do just quickly is disruptive behavior is sort of an extreme. It's a bad extreme, and it needs to be dealt with. But I think most of it is it's really emotional intelligence. You're getting physicians to understand, one, that they're a member of a team. Two, the care is extended beyond their silo. Multiple physicians, multiple settings, and you're going to have to take responsibility. And oh, by the way, your performance is being measured either from satisfaction or from quality metrics. What can we do to actually make you succeed? So it's emotional intelligence, which is self-awareness. The other part, and control, and the other part of it is teaching them communication skills, teaching them relationship skills, teaching them collaboration skills. So there's a tremendous opportunity, even when they're not disruptive behavior, to move them along that chain to get to be more satisfied and have better outcomes.
Good, thanks. That was concise. You covered about an hour's worth of material in 2 minutes. Well done. We've got a couple questions about how to measure success, and I think this is always an issue that we discuss on any of these initiatives. How do you measure success? So I'll give Dr. Guerin a minute to think about how they'll measure the success at the American Center of some of these things that we have underway. But I can tell you that the research is somewhat still in its infancy, particularly as you think about healthcare, because we haven't thought about these things before. But there's research out there that shows that physicians with a higher level of empathy do a better job managing chronic disease, and teams that communicate better and have better communication skills, particularly in trauma situations, have better outcomes. And there's a good bit of studies in the nursing field that high levels of emotional intelligence correlate with particularly career success and turnover and career satisfaction. But really what we're looking for are organizational results and organizational impact. So the idea that physicians now are using 360 assessments or 360-degree evaluations to improve performance, and that's been shown to improve some things. But Dr. Guerin, what are you looking for at the American Center when you think about physician success as we go down this road?
Well, that's a great question, and I don't know that anybody could tell us exactly what measures we should look at to determine that. I will tell you that one of my roles at this facility is to oversee quality, and quality as we define it. And like many organizations, we are, for instance, looking at patient satisfaction as a measure of quality. And I will tell you that if you take our pre-opening measure of all the physicians that are practicing at this facility, there wasn't a whole lot of green on the ledger of patient satisfaction. There was an awful lot of red. And I think if we do our jobs as physician leaders that have brought the idea of emotional intelligence into our leadership styles, if we are doing our jobs and let that filter down to every other physician and, quite honestly, every associate in the building that we work in, then we should see the green or the red turn to yellow to turn to green. And the focus on patient and family-centered care. If we have been successful in that, I think the natural byproduct of that would be a collective increase in the emotional intelligence of everybody that comes through the door here working.
And I think we have time for another question, and it's a pretty broad
question. Can I just throw one thought out there?
Sure.
It's one of the. This sounds very basic, but it's probably true. one of the basic ways is to just measure physician satisfaction. And now satisfaction is not just are you happy, but is do you feel like you're delivering good care? Do you feel like the staff respects you? Do you feel like if the group is collaborating? There's a whole series of questions around what satisfies physicians. And what I think you find is physicians who are satisfied, and whatever you need to do to get them to be satisfied, will improve their emotional intelligence, will improve engagement, will improve patient outcomes. So maybe looking at some of those satisfaction surveys is crucial. And one of the things that I'm saying is physicians are getting less and less satisfied. I mean, it's more stress, more burnout, more changes in the way they deliver care. But their satisfaction levels are going down. So if we bring up their satisfaction levels, that's a step in the right direction. That to me is part of success.
And how do we accomplish this? We've had a few questions about this. Within the organizational culture, can we talk for a minute about the need for organizational leadership support for this sort of initiative? So Dr. Guerin, for instance, we know the leadership group at UW Health, and this probably wouldn't have happened without them driving this because they're trying to create a certain culture. And if that's not there, we're going to struggle to be successful, right?
That's absolutely true, and really from the highest levels, both of the hospital, our physician group, and the medical school with which we're associated, if you don't have the leadership commitment to it, clearly it's not going to happen, I would say.
And I think we have time for one or two other questions. This one's rather simple and straightforward, but Ted, I'll ask you. Someone asked, how is EQ different? Thinking of staff, not necessarily physicians, but thinking of frontline staff and the role of emotional intelligence. How is emotional intelligence different from just straight likability? How are those two concepts related?
I think that likability is a little bit more narrow of a construct. So if I think about somebody that's likable, they're probably somebody that's high in agreeableness. They might be somebody that's high in extroversion. Sometimes people are outgoing, are perceived as being more likable. But one of the things that we find with extroverted people is that they're oftentimes very low in emotional intelligence, just because they're the loud, person with all of the life in the room at the party. Maybe they're not actually very aware of how they're being perceived. So, sometimes that person that you spend 5 minutes with that's very likable, if you spend 10 minutes with them, that you would find that they're not actually very likable. So I think that likability is just a somewhat different concept than emotional intelligence.
And I think that points out the need for really understanding what these things are. So, and I think to Ted's point earlier, people sometimes think of emotional intelligence as this sort of vague likability or awareness measure, when in reality we have to break it down to what are those sub-constructs. And again, you think about the nurse who's high in empathy but low in social awareness. Now she's got something to work on. Or the physician who scores high or low in one other area. We're not talking about a generalized score of high or low emotional intelligence, but something that's a little more concrete that you can actually do something with. That's the goal. We have to do something with it. Right. And I'll try and wrap up here quickly. One of the things that we found is important with physicians generally, whether we're talking about emotional intelligence, disruptive behavior, performance, is adding some structure to all of this. So one of the things that we've done, and Dr. Guerin referred to this, is start to define what the performance expectations are, particularly these behavioral expectations. Work those into essentially part of the job description. This is what it means to be a physician at UW Health. Work those concepts into the interview so that we think about these things as we bring them into the organization, and then start to give them tools to meet these new expectations, including the thing that we found is valuable is using an assessment like the tool we've developed or some of the others that are out there to get a baseline, to understand your strengths and weaknesses, and start a developmental plan. Because to Dr. Rosenstein's point, this isn't about screening out physicians. This is about positioning them for success as incredibly valuable resources. The system is only going to be as successful as its physicians, but we've not necessarily done a lot to make them successful outside of the clinical frame of reference. So that's been what we're striving to do. We're going to wrap it up here. We have a lot of questions that we didn't get to, but we'll try and respond to those as soon as we can. And I know that the folks from Becker's have been making you aware that the presentation, the slide deck, and the webinar itself will be available online, and they'll get that information to you. I want to thank Dr. Rosenstein, Dr. Guerin, and Ted for joining us. Always an interesting discussion, which I'm sure we'll all end up continuing offline as things progress. But we appreciate everyone's time and hope you have a great day.